Thank you, Mr. Chairman. It's my honor to participate in our 17th annual Transplant Chapter Congress. The topic of today is the crossing the renal hurdle in liver transplantation. Well, for just historical overview, the first orthotropic liver transplant in Egypt was done in August 2001. I have the honor to be one of the team who did this transplant as a nephrologist, of course. Only living donor liver transplant is performed here. Currently, there's about 20 centers in Egypt performing liver transplant with success rate equivalent to the international rates. Unfortunately, the data registry for liver transplant is not that updated. On the national level here, not internationally. The only paper I found documenting our results in Egypt was 2012, and it was updated back to 2014, done by National Liver Institute in Minufeya, Dr. Ibrahim Marwani Tal. And by that time, after 11 years of starting the first liver transplant, they performed around 2,000 cases, and they were distributed between the governmental and private sector equally. The abnormal kidney function is more common in liver candidates in the MELD era. MELD is the model for end-stage liver disease, because before the MELD era, they used to be very picky regarding the recipients in view of their kidney functions. Now they expanded their criteria and they're accepting more and more patients with different degrees of kidney impairment, starting from stage 1 up to those on dialysis. So they are increasing their pool for candidates for liver transplant. Yet the limited utility of estimation or of the equations in candidates and with for liver transplants, due to the different estimated GFR equations that we have, they lose their sensitivity when the GFR is below 40. As you can see here, that for those patients, when the patients have a GFR above 40, the different formula for estimation are comparable. While below 40, you can see a very large gap between the different formulae. Still, the iothalamate is the gold standard for picking the candidates for liver transplant. Yet nowadays, renal isotope scan, RIFLE, and AKIN became more reliable tools for assessment of kidney functions for liver transplant candidates. Classification of renal impairment in cirrhosis. We have AKI in setting of cirrhosis according to the RIFLE criteria, CKD in setting of cirrhosis according to KDUKI, and acute on top of CKD in cirrhosis. It's defined as a rise in serum creatinine above 0.3 milligram per deciliter in less than 48 hours, or an increase in serum creatinine more than 50% from the baseline, or in patients with cirrhosis whose baseline GFR has been below 60 milliliter per minute, calculated with MDRD formula for more than 3 months. The KDIGO urine output criteria, which is based on urinary output for the diagnosis of AKI, stated that urine output below 0.5 milliliter per kg body weight for 6 to 12 hours. This is stage 1. Stage 2 is below 0.5 milliliter per kg for 12 hours or more. And if it exceeds 24 hours, this will be stage 3, or anuria for 12 hours. The International Club of Ascites have new definitions for the diagnosis and management of acute kidney injury in patients with cirrhosis, where they consider the baseline serum creatinine is a value of serum creatinine obtained over the last 3 months, or the value just obtained before entering the hospital, and definition of AKI, which is increase in serum creatinine above 0.3 milligram per deciliter within 48 hours, and the stages, as we mentioned, stage 1, 2, 3, and progression, whether to progressing or regressing, response, partial or no response, or full response. These are the definitions made by the International Club of Ascites to unify the language that we speak with, because there was always a debate between us and the hepatologist about these definitions. Well, in this nice study I found, they found that you can see here that the patients studied here by Nadim et al. Over 280 patients, almost 60%, according to the rifle criteria, they didn't have any renal affection, while those having risk were about 12%, injury almost 7%, and failure almost 23%, among them hepatorenal syndrome and ATN, especially, of course, ATN was on clinical diagnosis. Those patients, as we will see here, the recovery rate for them, for those at risk, almost recovered fully, 94% within 1 to 3 months. Injury, almost 75%, also within the first 3 months. ATN was the lowest among them all to recover within the first 3 months. And hepatorenal syndrome, of course, they showed the best results, because this is, we are dealing with a rather normal kidney, and when you perform the liver transplant, this gives you the best results and the kidney starts to function immediately. I like this algorithm for those who will be confronted with such cases and they have to assess, because if you have normal kidney function, of course, you can allow your team to perform the liver transplantation alone. If you have acute kidney injury in the candidate, see if it persists less than 3 months, then you can again give them the allowance to start the liver transplant alone. If it persists for more than 3 months, then this will be considered as chronic CKD, chronic kidney disease, and accordingly you will see if it's stage 1 to 3, they can perform liver transplant alone. If it's stage 4 or on dialysis, or end stage, then you should encourage simultaneous liver and kidney transplantation. If the patient after liver transplantation developed renal failure or acute renal failure, and this persists for more than 3 months, and the patient was meeting the simultaneous liver and kidney listing criteria pre-transplantation, then prioritize this patient and encourage him to go for kidney transplantation after liver transplantation. And actually we performed quite a few cases of these patients who already received liver transplants, and then we performed kidney transplant after that in our center. Evaluation of renal function in patients with cirrhosis. Serum creatinine measurement should be used to evaluate renal function in patients with advanced cirrhosis until more reliable methods of measuring renal function become generally available. Cystatin C, maybe exogenous clearance markers also to be kept into consideration. GFR-derived equations should be used cautiously for assessment of kidney function in cirrhosis, since they tend to overestimate the GFR, especially, as we said, when the GFR is below 40. Renal involvement in the peri-liver transplant period. Before transplant, you might have hemodynamic-related GFR decline as GI bleeding, lactulose, diuretics, infections, etc. Hepatorenal syndrome, pre-existing CKD, parenchymal renal disease associated with liver disease, IgA nephropathy, and membranoproliferative GN, membranous nephropathy, and bilirubin cast nephropathy. At the time of transplantation, you might have ATN, residual pre-transplant renal dysfunction, CNI-related acute hemodynamic decline in GFR, and after transplantation, ATN, post-transplant diabetes, post-transplant hypertension, and CNI-related acute hemodynamic decline in GFR. Differential diagnosis of AKI in patients with cirrhosis: pre-renal azotemia, secondary to renal hypoperfusion, intrinsic renal disease, failure, structural damage to the kidney, post-renal failure, obstruction of the passages of urine. Of course, we're all familiar with the pathophysiology of pre-renal AKI, which is the loss of the mechanism of afferent arteriolar vasodilatation in response to circulating prostaglandins, and the efferent arteriolar vasoconstriction in response to the angiotensin II which are blocked on the afferent level by non-steroidals and on the efferent by ACE inhibitors and ARBs. And both mechanisms of compensation work together to increase glomerular blood flow and maintain intraglomerular hydrostatic pressure requiring for the proper filtration. Of course, you may lose this mechanism when there is severe cases of hypovolemia. These are some of the common hepatic disorders causing renal dysfunction. Hepatitis B, as we all know, membranous essential cryoglobulinemia, hepatitis C, membranoproliferative, also cryoglobulinemia, alcoholic liver disease, IgA nephropathy, obstructive jaundice, prerenal azotemia, primary biliary cirrhosis, ANCA-positive vasculitis, and membranous primary sclerosing cholangitis, membranous GN and ANCA-positive vasculitis, Wilson disease, renal tubular acidosis type 1, and alpha-1 antitrypsin deficiency, membranoproliferative GN, antiglomerular basement membrane disease. Systemic diseases involving both liver and kidney, like drug toxicity, example acetaminophen acetyl salicylic acid, granulomatous diseases as sarcoidosis, infectious diseases as leptospirosis, infiltrative amyloidosis, inflammatory lupus and Sjogren syndrome, non-alcoholic fatty liver disease and diabetic nephropathy, preeclampsia and HELLP syndrome, polycystic kidney and liver disease, autosomal dominant or autosomal recessive forms, sickle cell disease, and shock states, congestive heart failure, sepsis, hypovolemia, etc. These are also some comparisons that you might use to differentiate between prerenal acute tubular necrosis, hepatorenal syndrome, and primary renal disorders. Urinary sodium is much higher in those with primary renal disorder. Urinary creatinine over plasma creatinine ratio, it's higher in the over 30 in hepatorenal syndrome. Proteinuria, of course, will be more evident with primary renal disorder. Urinary sediments in acute tubular necrosis, heme granular casts, and primary renal disorder, RBCs and YBCs casts. Precipitating factors in renal failure, decreased effective circulatory volume. In acute tubular necrosis, you can add to the defective circulatory volume the nephrotoxic agents, hepatorenal syndrome, advanced liver disease and GI bleeding, spontaneous bacterial peritonitis, etc., and dependent on the primary renal disease on the type of renal disease. This is also another algorithm for assessment of the kidney status in liver transplant candidates. You may ask yourself when you are confronted with such case, is the GFR normal by doing the daily serum creatinine or doing at least one cystatin C measurement and consider measurement of GFR by exogenous marker if available? Is renal dysfunction acute or chronic? Previously, if they have the data available like serum creatinine, urine analysis, ultrasound, etc. Is there a long-standing diabetes or not, hypertension, or a family history of CKD? And if CKD is present, consider workup. Is renal dysfunction from a prerenal state, diuretic withdrawal, albumin infusion, evaluation for infection, evaluation for GI bleeding? And is renal dysfunction from parenchymal parenchymal disease or obstruction by urine analysis, quantification of urine protein, urine sodium, FeNA, etc. Is there hepatorenal syndrome? Are there metabolic disturbances? Is dialysis needed? And if you've reached this state, then is simultaneous liver and kidney transplant is appropriate. The hepatorenal syndrome, in this study, the role of the nephrologist was shown to be that you should make sure that the diagnosis is correct, pharmacological therapy to reverse hepatorenal syndrome, renal replacement therapy in hepatorenal syndrome, and decision-making regarding options for transplantation. The pathophysiology of hepatorenal syndrome, you have portal hypertension leading to splanchnic vasodilatation, decreased effective circulatory volume, and activation of renin-angiotensin-aldosterone system. This will lead to renal sodium avidity leading to ascites and renal vasoconstriction leading to hepatorenal syndrome. Clinical presentation of hepatorenal syndrome, we have type 1, which is a rapidly progressive and very aggressive form, where there's doubling of the initial serum creatinine to a level of more than 2.5 milligram per deciliter in less than 2 weeks. and then it usually develops spontaneously or following precipitating factors as spontaneous bacterial peritonitis or GI bleeding, and patients are usually very ill and severe jaundice, coagulopathy, and liver failure. While the second type, which is type 2, it's moderate renal failure. It's less severe form. Creatinine is almost between 1.5 to 2.5. It usually evolves slowly over weeks and even months, typically in patients with ascites refractory to diuretic therapy, and patients are usually less ill than those with type 1 mild degree of jaundice and coagulopathy. Hepatorenal syndrome workup in 2017. They made the diagnosis and revised it. Last time it was revised on 2007, and then it was revised after 10 years later, and they came up with the major criteria for diagnosis, which are, and you should have the 4 major criteria to confirm the diagnosis of hepatorenal syndrome, which is low GFR, absence of shock, ongoing bacterial infection and fluid losses, and no sustained improvement in renal function, which means decrease in serum creatinine below 1.5, and proteinuria is less than 500 milligram per day, and no ultrasonographic evidence of obstructive uropathy or intrinsic parenchymal disease. Another additional minor criteria, they are not required, but they confirm the diagnosis when you have urine volume below 500 milliliter per day, urine sodium levels less than 10 milliequivalent per day per liter, and urine osmolality greater than plasma osmolality, urine red blood cell count of less than 50 per high power field, and serum sodium concentration less than 130 milliequivalent. But beware that these criteria are very debatable, the minor one I mean, because urinary indices are not considered major criteria, as it's sometimes you can find different measures in ATN rather than the hepatorenal syndrome, and vice versa. These criteria are not, the minor criteria are not very accurate, so just keep in mind the major one for diagnosis. As you see here, that the worst diagnosis among the patients with cirrhosis are those for, regarding the survival, are those for hepatorenal syndrome. You can see that the worst survival among those patients when they develop hepatorenal syndrome, while those with parenchymal nephropathy, hypovolemia, infection are not that bad regarding the survival. For prevention of hepatorenal syndrome, we have general measures: treat any source of infection, discontinue any nephrotoxic medication, discontinue antihypertensive agents as ACE inhibitors or ARBs, assess effective circulating volume. Some also measure some special considerations for spontaneous bacterial peritonitis, as 1/3 of the patients of SBP will develop renal involvement or impairment despite antibiotic therapy. Patients who receive albumin in addition to antibiotic have been shown to have a lower incidence of renal impairment and death compared to those treated with antibiotics alone, although antibiotics alone have not shown to directly reduce the incidence of hepatorenal syndrome. Primary prophylaxis of spontaneous bacterial peritonitis with norfloxacin reduces the incidence of spontaneous bacterial peritonitis, which itself is a risk factor for hepatorenal syndrome. Large volume paracentesis, removal of more than 5 liters per 1 paracentesis, usually precipitates post-paracentesis circulatory dysfunction, and which can include renal failure in up to 20% of patients. Giving albumin at a dose of 8 grams per liter, which is almost 1 vial of acidic fluid. The vial is 12.5 grams, so yeah, it's always 1 vial. Acidic fluid removed has been shown to reduce the incidence of renal failure, but not mortality. The rationale for various treatment options for hepatorenal syndrome: improving the effective arterial blood volume expanders, and reducing the extent of splanchnic and or systemic arterial vasodilatation by vasoconstrictors, and eliminating portal hypertension by TIPS, and removal of toxins, intermittent hemodialysis. Correcting liver dysfunction and eliminating portal hypertension by liver transplantation if possible. How is volume expansion used in the treatment of type 1 hepatorenal syndrome? Albumin not only improves the effective arterial blood volume, but it may also reduce systemic arterial vasodilatation by binding systemic vasodilators. And the recommended dose is 20 to 40 grams of albumin per day in combination with vasoconstrictors after the initial dose of 1 gram per kg of body weight on the first day. يعني بندي تقريبا أول يوم حوالي 6 vials divided on 3 doses if we are talking about a 70 kilogram patient, and you keep on 1 vial every 8 hours for the next coming days. Albumin alone appears to be ineffective in the treatment of hepatorenal syndrome. Albumin is always indicated when doing paracentesis. Intravenous albumin improves renal function and survival, combined with vasopressors improves the outcome. Vasopressors, again, the hepatorenal syndrome workup showed that we have terlipressin with 0.5 to 2 milligram intravenously every 4 to 6 hours with stepwise dose increments every few days if there is no improvement in serum creatinine, up to maximum dose of 12 milligram per day as long as there are no side effects, and the maximum dose is 14. Vasopressin 0.01 unit per minute to 0.8 unit per minute continuous infusion, and noradrenaline and titrate to achieve a mean arterial blood pressure increase 10 millimeter mercury. Midodrine and octreotide. Midodrine with 7.5 to 12.5 orally 3 times, titrate to achieve 15 millimeter mercury increase in mean arterial blood pressure from baseline, and octreotide 100 to 200 micrograms subcutaneously 3 times daily, or 25 microgram bolus followed by intravenous infusion of 25 mic per hours. Dopamine, small dose, it's debatable as we all know, but still have a role in, for some authors in hepatorenal syndrome. Should dialysis be used for the treatment of hepatorenal syndrome? Intermittent hemodialysis has been used as a short-term bridge to liver transplantation. However, there is no evidence that it increases the long-term survival without transplantation. Liver dialysis therapy, liver support therapy usually consists of a series of at least 3 treatments, last 6 or more hours each, and is performed with the following aim: recovery to pre-decompensation status, bridging the time for liver transplantation, keeping the patient in a condition that allows successful liver transplantation, full recovery, and graft recovery. Liver dialysis indications: bridging for transplantation, intoxication as in suicide, hepatorenal syndrome, post-transplantation dysfunction or non-function, acute on chronic liver failure caused by viral infection or autoimmune disease, metabolic dysfunction, example hemochromatosis, and decompensated alcoholic cirrhosis, cryptogenic cirrhosis. This is the mostly used liver dialysis machine, which is called the Prometheus system, the 2 and 1, where Prometheus or Prometh 1 column contains highly porous neutral resin for the removal of albumin bound toxins such as bile acids, aromatic acids, etc. And the Prometh 2 column contains anion exchange resins with spongy inner portions to increase surface area. It contains positively charged ligands capable of binding negatively charged substances, example unconjugated bilirubin. Recommendations: there is insufficient data to advocate tips in hepatorenal syndrome AKI, but it could be suggested in selected patients with hepatorenal syndrome. Liver transplantation is the best therapeutic option for patients with hepatorenal syndrome regardless of the response to drug therapy. The decision to initiate renal replacement therapy should be based on the individual severity of illness, and the indication for liver kidney transplantation remains controversial. This procedure should be considered in patients with significant CKD or with sustained AKI, including hepatorenal syndrome AKI with no response to drug therapy. Renal dysfunction post-liver transplantation. One of the most common complications after liver transplantation chronic CNI toxicity, which causes structural changes to the renal parenchyma, is the main cause of renal failure, but other causes have to be ruled out. The cumulative incidence of renal impairment in more than 69,000 patients, non-renal transplant recipients, has been estimated, showing that 8% show renal impairment after 1 year. This increased to 14% after 3 years and reaches up to almost 20% after 5 years post-liver transplantation. The risk factors for renal dysfunction: we have pre-transplant renal dysfunction, pre-transplant hepatorenal syndrome, duration of renal dysfunction in prior to liver transplantation, calcineurin-induced nephrotoxicity, hypertension, diabetes mellitus pre-existing or new onset diabetes after liver transplantation, nephrotoxic drugs, post-operative acute renal failure, renal replacement therapy requirement in the pre-transplant or post-transplant period, HCV infection, and older age. Renal sparing strategies: induction with basileximab, adequate control of diabetes and hypertension, add ARBs to decrease renal arteriolar vasoconstriction. After 1 month, add everolimus. And we all wish for the ideal immunosuppressive agents or protocol, which should be selective, prevent rejection, does not damage the kidney, does not promote malignancy, does not aggravate cardiovascular CVS factors, improves compliance. And this is a suggested selection criteria that we implement in our center, where we always prefer patients with serum creatinine below 1.6, GFR above 60, measured whether by the creatinine clearance or isotope scan, and usually we take the average if there is discrepancy between both. And ultrasound, we prefer the patient to be normal sonographically, and proteinuria. It's better to have a patient with less than 500 milligram per 24 hours protein. Thank you so much.